My name is Tara Haelle. I'm the Health Beat Leader for Infectious Disease for AHCJ, and this webinar is one in a series of topic-specific training opportunities to brief health journalists on the latest information in a particular health area and give you story ideas or story resources for your work. Today's topic is what Kennedy could do, reporting on U.S. vaccine policy and the powers of the Health and Human Services Secretary. Joining us today is Paul Offit, Professor of Pediatrics and Infectious Disease Physician at Children's Hospital of Philadelphia, and Dorit Reese, a Professor of Law who specializes in vaccine policy at UC Law San Francisco. Our guests will each present on their respective areas, and then we will open it up to questions. You can put questions in at any time. You don't have to wait until we get to the Q&A, but please make sure you put your questions into the Q&A space. You'll see at the bottom of the screen there a Q&A box, like a little question mark. You want to put your questions there instead of the comments. So make sure that you keep all of your questions there, and then I will direct your questions from there to our guests. Looks like we have most people have gotten in here, it looks like. So I think we'll go ahead and get started. Paul, let's go ahead and you can start us off.
Okay, thank you. So Tara has asked me to comment on how a vaccine is made. So I will start at the beginning. Let me go here. Okay, so typically the way vaccines are made is first there's preclinical research, meaning research in experimental animals. So for example, I was fortunate enough to be part of a team at Children's Hospital of Philadelphia that created the rotavirus vaccine. For 10 years, we were able to develop a small animal model, mice, that enabled us to study the disease because we were able to get the mice to have symptoms and signs similar to human infection. And during that time, we could figure out then which parts of the virus coded for proteins, or what genes of the virus coded for proteins that induced a protective immune response, which genes of the virus coded for proteins that induced, in this case, diarrhea for our vaccine. And that took about 10 years to do. That's actually fairly fast. If you look, for example, at the mRNA vaccines that were made by Pfizer and Moderna, the preclinical research that was done in experimental animals, particularly primates, was started with Drew Weissman and Katie Carrico in 1997 when they first started working on mRNA vaccines. And then with the SARS-1 outbreak in 2002, Kizzy Corbett and Barney Graham at NIH started working on mRNA vaccines. So when people say that the mRNA vaccine was made in 11 months, that's not true. The work started in 97, and then the preclinical work really started in the early 2000s. So in any case, so now you think you've got your vaccine, and then you do phase 1 studies, where it's so-called proof of concept studies, where you have to prove that if you have more than one strain in the product, that you need all the strains that are in there. You have to prove that you have the right buffering agent, the right stabilizing agent, the right vial, the right number of doses, and that's something that you do in usually 100 or so volunteers. So now you think you've got it. You think you've got the right number of strains, the right strains, and everything else you need to move to the next phase, which usually involves several hundred volunteers. That's phase 2. And there what you're doing is you're trying to make sure that you have a consistent immune response and that you don't have at least a common serious side effect, which you'll pick up in a few hundred people. Now you're ready to see whether or not it works in a clinical trial. So you go to phase 3. Phase 3 involves tens of thousands of people. For our rotavirus vaccine trial, it was 70,000 person placebo prospective controlled study that was done over about 4 years and involved a variety of countries. Took about $350 million to do. It was done in 11 countries. And that proves that your vaccine works and that it's effective, and it proves that it's safe, at least to the point that it doesn't have an uncommon side effect. But you haven't disproven a rare side effect. That's only going to occur post-licensure or post-authorization. And that's shown here. There's a couple mechanisms that are in place, have been in place really since the 80s, to look at vaccines once they're given to millions and millions of people. So one is the Vaccine Adverse Events Reporting System, which is something that's co-managed by both the Centers for Disease Control and Prevention and the FDA. And anybody can report to this. Parents can report, patients can report, personal injury lawyers can report, anybody can report. And it's a noisy system. It enables you to detect a safety signal rapidly. And that happened actually in the late 90s with a rotavirus vaccine that was made by Wyeth, where suddenly there were these increased cases of intussusception, which is an intestinal blockage, which can be serious. And it happened also with the COVID vaccines with myocarditis. That was really first noted in the vaccine adverse events reporting system. But it only allows you to say, got a vaccine, had a problem. It doesn't really prove that it was causally associated with the vaccine because there's no control group. So it can't assess a causality. The only way to assess causality really is with the vaccine safety data link, because here what you have are 9 participating integrated healthcare organizations of more than 12 million people. When a vaccine rolls out, not everybody gets it all at once. Some people get it, some people don't. So you can very quickly see using this database whether or not you're more likely to have suffered that problem if you got the vaccine than or if you didn't. So this is the system that proved that myocarditis was a consequence of the vaccine. It's a very sensitive system. When people say or fear that there aren't safety systems in place, they're wrong, because this is an example of it. I'll give you another example. When in February of 2021, the J&J's vectored virus vaccine was released, it was shown in not too long a period of time that it was a rare cause of clotting, including severe clotting, that could occur in about 1 per 250,000 people. So something that rare can be picked up by the vaccine safety data link. And very, very quickly, a mechanism was assigned for why that happened. And none of these were anticipated. I mean, when people say, well, why didn't you know this pre-licensure? No one anticipated that the mRNA vaccines would cause myocarditis. Nobody participated or anticipated that the vectored virus vaccines would cause clotting. So, but anything that comes up can be picked up in that. But again, you need to have a control group, and that's what this provides. One of the problems with pre-licensure studies is that things come up that aren't necessarily real. So I'll give you an example. I'll go back a couple slides here. On phase 3 studies, for example, with our rotavirus vaccine.
Paul, I'm going to jump in for a second because I made a mistake in the beginning. One of the things I wanted to make sure people knew, the reason we're starting with why vaccines are made is because people don't understand why vaccines are made initially and how vaccine injuries are reported. They won't understand later when Dorit goes over what Kennedy can do, how he is able to influence this. So I just wanted to jump in and explain that context there. Sorry about that. Go ahead. Continue.
You mean why we make vaccines? Is that your question?
No. I was letting people know I should have better set up you before we started.
Okay.
And I wanted people to understand why we were starting with why vaccines were made. I think people may have been confused with the title of the webinar. I want to make sure people knew why we were talking about the making of vaccines, because they need to understand like the steps along the way so that when we get to what Kennedy can do, people understand the influence he can have over this process. Does that make sense?
Sure. No, Kennedy
I'm
will.
providing context. I'm not asking a question. You can continue.
Okay, thanks.
Sorry about that.
So Kennedy will constantly ask for transparency. He believes that there are things that are being hidden behind the curtain that no one sees. He doesn't really mean that. What he means is that people aren't confirming his bias. His bias, for example, that MMR causes autism, even though study after study showed that it didn't. He believes that it does, because he has this fixed immutable belief. So that's what he means by transparency, that we're not showing data that he comports with his preconceived notions. But in any case, the point I wanted to make about phase 3 studies is kind of the tyranny of small numbers in a large database. With the rotavirus vaccine, for example, which was a 70,000 person placebo-controlled, prospective controlled trial of sort of children getting the vaccine at 2, 4, and 6 months of age. There were 9 cases of seizures in the vaccine group and 2 in the placebo group. That was statistically significant. But when the vaccine was then given to millions and now tens of millions and now hundreds of millions of children, there is no greater instance of seizures in the vaccinated versus unvaccinated group. Similarly, there were 5 cases of a disease called Kawasaki's disease, which is a sort of autoimmune phenomenon that was seen in the vaccine group, but none in the placebo group. That too was statistically significant, and that too was then looked at when the vaccine was given to millions of children. Of interest, there were 5 cases of arm and leg fractures in the placebo group and none in the vaccine group, which is to say that was statistically significant. The rotavirus vaccine prevented arm and leg fractures, which is, of course, ridiculous. And that too disappeared as you got into larger databases. All right, so that was vaccine safety database, that's vaccine safety data link. The other is this so-called vSafe system, which is kind of this message check-in. And where this really helped with the COVID vaccines was with pregnant people, because you knew that pregnant people had a roughly 2-fold increase of being hospitalized and killed by SARS-CoV-2 virus than people who weren't pregnant. And but when the vaccine was tested by Pfizer and Moderna, pregnant people weren't really included in that study. So historically, the CDC will never recommend a vaccine for pregnant women where the vaccine wasn't studied in pregnant women. But at the same time, you knew that pregnant women were at a high risk of having serious and occasionally fatal infection. So what they said was that you could reasonably make that choice to get that vaccine. And with that, you had tens of thousands of people who did make that choice to get the vaccine, and they would report through this vSafe system so you could see whether there was any problems either with the pregnancy or with the any risk factors associated with for the newborn or then the unborn. Okay, that's all I have to say. Thank you very much.
Sorry for interrupting you and throwing you off about that, Paul. One thing that I wanted to add there is when they make that recommendation, that advisory committee for immunization immunization practices, and then also at the FDA, the vaccines, remind me what VRBPAC stands for, vaccines and biological products.
Vaccines and related biological products advisory committee.
Right. Could you explain briefly what each of those committees are? Because I know that Dorit is probably going to discuss appointments to those.
Yes.
Yeah, so the FDA is a regulatory agency. The CDC is a recommending agency. So I'm on the FDA's Vaccine and Related Biological Product Advisory Committee, otherwise known as the FDA's Vaccine Advisory Committee. So we get data to examine. For COVID, for example, in December of 2020, we got roughly 400 pages to review from Pfizer, both from Pfizer and from the FDA. So Pfizer will submit, for example, their emergency use authorization, about 200 pages long, that goes through all those data: phase 1 data, phase 2 data, phase 3 data, and then the FDA also reviews every piece of data that Pfizer has and make sure that there's no misrepresentations or omissions. So you'll get 400 pages of data to read in the week before you actually meet. Same thing was true for the Moderna vaccine. So you're getting about 800 pages to read, which are all available online. So there's nothing hidden. You can just go right to the FDA's website and see that. So then we recommended authorization, or in some vaccines, licensure, and then the FDA considers that recommendation. We're an advisory committee. We give advice. You can always ignore our advice, but then they then say, okay, I agree, this should be authorized. Then that goes to the CDC, who then looks at the same data and then decides whether or not to make the recommendation. And that committee is the Advisory Committee for Immunization Practices, or ACIP. I was on that committee in the early 2000s. And again, I think the system works very well. I think that what works well about it is that not everybody reads all the studies. I mean, the people who sit around those tables, at least collectively, have read all the studies that led up to that vaccine, collectively have that expertise, and I think have given us good advice. We live 30 years longer than we did 100 years ago, in large part because of vaccines. We have vaccines that are very safe and very effective, thanks to the system.
And how influential are the recommendations of ACIP and VRBPAC?
They're influential. I mean, I think that there are times when, even during the COVID pandemic, the CDC director would choose to do something that wasn't necessarily recommended by the ACIP. But I think for the most, just like academic medicine, when you round, you give advice, and mostly people listen to your advice, but not always.
All right, thank you for that overview. We're going to move on to Dorit, and she's going to speak more about the policy side and the appointments that occur, and then we'll open it up to questions.
Yeah, so thank you, Tara and Paul. You just, that last...
Oh, sorry, I looks like I jumped you. I'm sorry.
No, that's okay.
Go ahead.
The last set of comments actually really helped me set up the topics I want to talk about, because I am going to start with the advisory committee that Paul ended with, and I'm going to start not from the point that Paul made, which is what do they actually do, but the legal issues surrounding them. And I want to give you in 15 minutes 4 topics that each of which would take 1 to 2 hours in administrative law. So it's more of a heading discussion, and I hope that people ask about the specific issues that interest them more. So the starting point is, as Paul mentioned, that we have in the system 2 really important advisory committees that help the process along. The Vaccine and Related Biologic Product Advisory Committee in the FDA, and Paul explained to you what it does, and the Advisory Committee on Immunization Practices in CDC. And I want to mention, before I go in, that ACIP, unlike VRBPAC, is mentioned in a number of statutes and has some statutory authorities that are important to this discussion. VRBPAC
When you say
advises, and it
statutory, you
advises,
mean it's in an actual law that Congress passed, right?
yes.
Okay, I just want to make sure.
I'll explain. I'm explaining. VRBPAC advises, and its advice is taken seriously by FDA, but ACIP also has the authority in statute, when it makes recommendation, to allow for coverage of vaccine in the Vaccine for Children program that pays for vaccines for uninsured or underinsured children. And the recommendation of ACIP also require insurance companies to cover the vaccines under the Affordable Care Act. So it also has statutory authorities. Advisory committees are always subject to the Federal Advisory Committee Act, which requires, most importantly for us, that the committee meetings be transparent, that they be advertised in advance, that, as Paul said, the materials will be online, and that people have a chance to comment, and that the meetings themselves will be publicly available. So we know what these committees do because they sit in public. The works groups don't, but the committees themselves sit in public and vote in public. Both of these committees are under charters, and as I mentioned, ACIP, but not VRBPAC, has actual power to affect access. The first thing to remember is that to exist, these committees need to have a charter renewed every 2 years. ACIP charter was approved in March 2024, VRBPAC in July 2024. Both of them are due for renewal in 2026. And I want to remind people that if the administration does nothing, the charters will elapse and these committees can no longer meet. The administration has to actively renew the charter and actively convene them. So one place the administration may choose to act is not to have these committees anymore. Although ACIP is mentioned in statute, those powers can be handled by someone else. The other thing to keep in mind about these committees is that the members of these committees are, under the statute, appointed by the Secretary of Health and Human Services. I will mention that in practice, so a lot of things are delegated to the Secretary of Health and Human Services, and the Secretary in practice in the past doesn't actually do all the things that are delegated to the Secretary. Most of them are done by others. In this case, most of appointment in practice used to be done by CDC and FDA. But because legally they're in the Secretary's hand, there's nothing stopping the Secretary from doing it himself. And I want to remind people that the Trump administration is coming in with an open agenda that is hostile to the administrative state, and Kennedy is coming in with an agenda that's openly unfriendly to the agencies under HHS, which means that existing norms may no longer apply, that they may change how things were done, and that the Secretary may take to himself the power to actively appoint officials. When it comes to removal, both members of both committees are removable at will by the Secretary. I will say that it has never been done. In practice, members of these committees have not been removed by the secretaries, but again, the Secretary has the legal authority. So in a worst case scenario, we can imagine Mr. Kennedy coming in, if confirmed, and deciding to replace the members of both committees with people that he would prefer to have in place. So one question is, what will happen with this committee? If, for example, ACIP is reconstituted and the new members vote to rescind recommendations, say, for the DTaP vaccine, that vaccine will no longer be required to be covered by insurance company. Doesn't mean they won't cover it, but they won't be required to cover it. It'll be voluntary and up to them. If the secretary reconstitute ACIP and ACIP removes coverage under the Vaccine for Children program, some vaccine will not be accessible to many children. About half the children in the country get vaccines under the Vaccine for Children program. Second topic. So besides the Federal Advisory Committee, federal appointees have power over appointment and removal of a number of people. And here a bit of background is important. Our administrative state has three types of personnel in it. What we call principal officers, and I'll talk about them in a moment, what we call inferior officers, and the majority of our administrative state is populated by tenured civil servants who since 1883 are subject to merit appointments. Until 1883, we had a system called the spoiled system, under which each new administration will bring in their friends and people in favor, give them administrative position. They would often use that to get a lot of money. And it would be a nepotism system. In 1883, a president was murdered when someone offered a job wasn't happy with when someone was not happy with not being given a job. And since then, we have in statutes that say that civil servants will be appointed after competitive examination. Why am I talking about this? Because the statutes are very vulnerable to constitutional challenge. It's not clear that today's court will find them constitutional. And the reason it's important is currently one of the things that protect FDA and CDC independence is that there are a lot of civil servants there. We can't assume that that will remain in place. The new administration already mentioned that they're going to weaken protection of some civil servants, and they may weaken protections generally, which may give them a lot more power over the administrative states, aside from the courts. The top two layers are appointed under the appointment clause of the Constitution. I know this is too much text, but the short version is that principal officers have to be nominated by the president and confirmed by the Senate, and I'll go back to that in a moment. And what we call inferior officers have to be, can be appointed by the president or by the courts of law or by the heads of department. Kennedy comes in, if he comes in as Secretary of Health and Human Services, that makes him a head of a department, and there are a lot of positions he gets to appoint. Some points that are related to the new administration and these appointments. Principal appointments like Kennedy, like since 2025, CDC director. In the past, CDC director was appointed by the president without confirmation, and that, like the commissioner of FDA, require Senate approval, Senate confirmation. Without that, the president has a problem. Historically, Senate confirmations take time, even at the best of time, even with the same party holding all offices. They used to take a minimum of 60 days in the past few administrations. They aren't a fast thing, which is one reason President Trump has floated the idea of recess appointment, which I think is no longer on the table. Some administrative law scholars are saying there's a legitimate reason to do that because confirmation is so slow. So past precedents suggest that it won't be immediate. Nominations won't be immediate. And it has to go through the Senate. And one of the questions for this line of nomination is who will vote on them? All of them have to be voted on by the Finance Committee in the Senate before they go to the floor. But in the past, health nomination went before the health, education, labor, and I'm blanking on the fourth one, a committee in the Senate. And there's rumors that the Health Committee may hesitate to hold hearings at this time. One of the things that would be a really good idea is to have those hearings and have people who have expertise with health ask questions about health. So principal appointments need Senate confirmation. Inferior appointments are made by the head of departments and people within the administrative state, and there's very little oversight with them. And there are a lot, when we say inferior officers, so officers in this case is described as people who exercise significant authority on behalf of the United States. These are not trivial positions. These are important positions. There's very little oversight of them, and there's probably more positions available to Mr. Kennedy than people he has that he would want to fill those positions in that case. He can put a lot of people in top positions in HHS with very little oversight. As I mentioned, the Trump administration openly wants to increase the control of the civil servant part as well, which will give them more control over the actions of career civil servants, weakening what used to be a safeguard against strong political interference in expert judgment. And the last part of the appointment picture that you need to keep in mind is that in the past 10 or so years, the Supreme Court has tightened the rules about appointment and removal. The Supreme Court had made it harder for Congress to protect officials from removal. It had found that there's only a narrow set of circumstances in which officials can have removal protections, and it had deepened the number of officers that have to be politically appointed. It found that a lot of officers that in the past were tenured civil service now have to be appointed politically, either by the head of department or through full president nomination and Senate confirmation. And the appointment and removal is another way that the new appointees, including Kennedy, if he's confirmed, can have control of the administrative state. Third topic, as I said, this is a bit of a whirlwind. Product removal, approval and removal. There's a lot of question of, can Kennedy actually remove products from the market? Two preliminary points. One, the powers under the Food, Drug and Cosmetics Act are in the act delegated to the Secretary of Health and Human Services, but since the act start have been delegated to the Commissioner of the FDA, which is a separate person. So there's two questions here. One, how much leeway will the Commissioner of FDA have compared to the Secretary? And here there might be a tension between previous norms, which said the Commissioner is independent, and a new reality in which the Secretary tries to aggressively take more power. So one is how will that relationship work? And the second one is what will the Commissioner want to do or not do? Here are the other things you need to know about products. There's a process that allows removing existing products from the market. Generally, it requires hearing, but the FDA can waive those hearings. And although I thought it's hard to waive, one of my colleagues that specializes in FDA more than I do said that the courts have been relatively lenient in allowing FDA to waive the hearing. But with or without hearing, there is a process, and the FDA can be taken to court both around the process and around the substance, and they'd have to defend their decision and show that it's not arbitrary and capricious in court, and they'd have to do it in a form that the plaintiffs picked, not that they picked. These cases are not going to go to the kind of judges that opponents to the Biden administration had success with in Texas and Louisiana. They're going to go where the plaintiff, which is probably a pharmaceutical company, wants to go. FDA has substantial more leeway for new products than for old products. Generally, and Paul maybe can add to that later in the questions, the requirement for clinical trials are set in negotiation between the FDA and the manufacturers. What's the placebo, how many people, and so forth. So FDA for new products can determine it and can raise the bar. So new vaccines, including vaccines to replace existing versions of vaccines, can face more hurdles than old vaccines and can be easier to slow down. And finally, the last thing to know about product approval, and then I'll talk for 5 minutes about compensation and open it to questions, is emergency use authorization is given by the Secretary of Health and Human Services, and the Secretary can revoke it, which for our purposes, for example, applies to COVID vaccines for children. The Secretary can choose to revoke those EUAs, and that would mean that COVID-19 vaccines are not available for children because the versions for children are different than the versions for adults, and they're not licensed. The companies chose not to ask for a license. Last topic, and I'll keep this as short as I can, is compensation programs. First point is the US is not unique in having a no-fault compensation program aside from the courts for vaccines. That issue seems to have a lot of misconceptions. There's about 25 countries that...
Can you say what a no-fault compensation scheme?
I'll get to that. Give me one moment. There's about 25 countries that do that. No-fault compensation programs are programs in which you don't have to show negligence, product problem, or other fault by the manufacturers. all you have to show is that the vaccine caused your harm and show your damages and you get compensated. So in a sense, it's a break from the courts. And the way it usually works is that these programs come with some liability protections for the manufacturers. United States has two such programs. The Vaccine Injury Compensation Program covers vaccine recommended for children and pregnant people as long as Congress added an excise tax for them. So COVID vaccines aren't covered until Congress moves on that. The standard there is relatively easy. The standard for causation, some injuries are going to be in a table of injuries where causation is presumed. And for others, you have to show it's more likely than not, a little more than a coin toss. There are liability protections. They're limited. You can go through the program and then go to court. For example, right now, there's a multi-district litigation against Merck over its Gardasil vaccine that covers more than 200 cases by people that went to the program and either lost in the program, or if their case lasts more than 240 days, they can go to court. Not for all claims, but for most claims, you can go to court. COVID vaccine are covered under the Counter Injury Compensation Program, which covers emergency countermeasures, not just COVID vaccine, but COVID tests and drugs, and has very expansive liability protections and a hard to meet standard. The standard is, I'm actually going to read this because the words matter here, that you have to show that the vaccine or the measure cause you harm with compelling, reliable, valid medical scientific evidence. And you have a year to file that claim. So you have to get that evidence in a year. And if it's an emergency, the product was just created, that's not always realistic. I will say that as a policy matter, it's really important both to preserve trust in a vaccine program and because it's the right thing to do. Vaccines have public benefits, so no individual should be left holding the bag for them. It's really important to provide people fast, generous compensation if they are, in fact, even maybe injured by a vaccine, and that program doesn't do it. The liability protections here are really hard. They're under the Public Readiness and Emergency Preparedness Act, and you can't go to court unless you show willful misconduct, intentional harm. I will mention that there's litigation about how broad that liability is, and in a number of cases, courts of appeal have said that for plaintiffs claiming vaccine injury, you can go to court because the liability protection in the act are too broad. They may be unconstitutional. But in another set of cases where parents sued because their children were given a vaccine in a vaccine clinic in school, a COVID vaccine, without permission, which shouldn't happen. I mean, children should not be given a vaccine normally without parental consent, but in a school clinic, sometimes there are mistakes. Parents sued when the child was accidentally given a COVID vaccine without consent, and courts that looked at that said PrEP liability covered that. The parents can't sue. So this is an area that's litigated right now. How much liability protection do we have under the act? What will happen under the new administration? This is my last slide. First, know that under the previous administration, there was a bill filed by Representative Gossar to overturn the Vaccine Injury Compensation Program and remove those liability protection. It was supported by the Freedom Caucus, about 22 other Republican representatives, and I expect it to be refiled. The question is, does the Republican Party want it to go forward or not? And I don't know. It might not be a priority, but it will probably be refiled. Kennedy, as secretary, can do two other things in relation to compensation. One, he can try and remove vaccines from the table of injury. To be covered under the Vaccine Injury Compensation Program, vaccines need to be in the table of injuries. He can remove that, but to do that, he will have to go through rulemaking procedures, which can take as long as 6 months or longer sometimes. So he'll have to go through a process, and he may be subject to judicial review. So it's not that easy, but it's doable, in which case the vaccine claims of vaccine injury under that vaccine will have to go to the court. What he can do more easily is, so COVID and some influenza vaccines are covered by a PrEP declaration, a Public Readiness and Emergency Preparedness Act declaration that protects against liability and sends it to the program, and he can revoke that and send COVID vaccines and those influenza vaccines to the courts. It's just been renewed by the secretary until 2029, but he can revoke it. So that's the thing I wanted to talk about. Happy to take questions.
Thank you both. Lots of questions have come in. I'm going to try and organize them. Some of this gets really into the weeds, so I hope I'll do that well. Just to review, so the key things here, and interrupt me if I miss anything, are that Kennedy can, even though usually the ACIP and VRBPAC members are appointed by the agencies, Kennedy himself can choose to dismiss the people who are currently in those positions and then reappoint whoever he wants. And it sounds like he could have extensive control over the civil servants in general throughout HHS. So it sounds like he could sort of fill the agency with his cronies in ways that would interfere with the usual way of doing things. Is that right? Okay. And then you mentioned that there could be a power struggle between the FDA commissioner and the Health and Human Services. What kind of thing might Kennedy try, like if Kennedy is confirmed, or whoever is in the position of HHS Secretary, where would the tension occur between the HHS Secretary and the FDA commissioner? Like, what might the HHS Secretary try to push the commissioner to do in terms of like that, where that tension could occur?
In theory, all the powers under the Food, Drug, and Cosmetic Act are delegated to the secretary, which then delegated them to the commissioner. So under the act, the secretary can, in theory, take any powers the secretary wants. There's no precedent for that and no history of that, and it will cause some tension, and the president might disagree. And by the way, in the background of this, everybody remember that the president has the power to remove any of these nominees at will. So there may be reason for the secretary to act cautiously, but under the law by itself, it's the secretary's power.
So one of the challenges we have in thinking about this is that we're aware that both Trump and anyone he appoints might try and bypass the usual way of doing things. So we kind of have to use our imagination in terms of figuring out ways that they might try and do stuff that has not been done before. And it sounds like one of those things would be the HHS Secretary trying to sort of take over the FDA commissioner's job if that was something
Yes.
that he wanted to do. Okay, and that could then influence like whether or not they try and remove products such it sounds like Kennedy could not unilaterally just go and say, okay, the polio vaccine has been removed. He would have to do it through a process, but he could he could bypass the FDA commissioner in trying to expedite that process. Is that right?
Yes, and part of it is, so to do it in a way that survives judicial review, you do have to do it to follow certain steps, and you would need the FDA professional staff to shore it up in a way that would withstand judicial review. Question is how much you would care. So in the first Trump administration, President Trump came in with an agenda and went ahead and did some of it. And one of the issues was that they didn't necessarily go through the steps. Before the Trump administration, administrations from both sides of the aisle won in court on arbitrary and capricious review about 60 to 70% times. In the first 2 years of the Trump administration, they lost on arbitrary and capricious review 94% of the time. And not because what they were doing couldn't survive judicial review, but because they haven't gone through the steps. So whether they will go through the steps or not next time, I don't know.
And then you also mentioned that Kennedy can force the FDA, the HHS Secretary can kind of push the FDA to ask for unrealistic expectations for trials, for example. Paul, what would be an example if the HHS Secretary wanted to push the FDA to say, hey, Pfizer, in order to get this vaccine approved, or in order to keep this vaccine, we actually want you to do a trial that does X, Y, Z. What's an example of the kind of trial that they might try and force pharmaceutical companies to do for vaccines that would be not ethical or unrealistic? Does that question make sense?
There we go. Yeah, it does. So typically the companies work with the FDA during these trials. I mean, I guess I got to watch Merck work with the FDA in designing its 70,000 person prospective placebo-controlled trial for the rotavirus vaccine, because they were coming off of another vaccine that was made by Wyeth that was taken off the market in the late 1990s because it was found to cause interception. So they wanted to know what would be satisfactory to the FDA. So that negotiation goes back and forth. The company will say, look, this is the way I want to do this. And the FDA will come back and say, no. But it's sort of like a guess what I'm thinking game the FDA plays. So then it goes back and forth until then the FDA doesn't say no anymore. And the assumption that is, okay, they can move forward this way. An unrealistic trial would be things that think people like Aaron Siri, who is sort of the chief lawyer for Informed Consent Action Network and now kind of RFK Jr.'s right-hand man. So when, for example, the pneumococcal conjugate vaccine that contained 13 different serotypes was put on the market, there was an existing pneumococcal vaccine that had 7 serotypes. So that in theory, this would be a better vaccine because it contains 6 more serotypes. Aaron Siri has said the problem with that vaccine, the PCV13, is it was never tested against placebo. Well, you can't test it against placebo if there's an existing vaccine out there that prevents pneumococcal infection, which can cause severe and fatal pneumonia, bloodstream infections, and meningitis. You can't ethically do that study. So when for example, the Aaron Siri says something like that, you can't do that. You can't ethically do it. So you can't hold at least a company to an unethical standard. So that's one example.
So you could get stuck in sort of this back and forth where the company wouldn't be able to do the trials that the FDA is saying they have to do because the FDA would be asking for something that's unethical, assuming that we had these people in charge.
No, well, that's what Aaron Siri had asked for. So yeah, you're right. So it's like, right, that's right.
And is there anything that, this is to either one of you, probably more to Dorit, is there anything Biden can do to slow the possible unwinding of vaccine recommendations? Because it sounds like if Kennedy filled ACIP, for example, with its with his cronies, he could try and get them to undo the recommendations and maybe get a rubber stamp from the CDC director. Can Biden do anything to stop that?
I don't think this is something the current administration can stop because the power is in the secretary's hand legally. What others can do is, if a recommendation is overturned hastily or without reasons, that can be a reason to go to court. And usually, so one of the issues is usually you can't go to court just for a recommendation because it has no practical effect. But because ACIP recommendation has an effect on coverage under the Affordable Care Act, for example, people who may lose coverage can go to court and say, this was arbitrary and capricious and we lost coverage. So they can challenge the specific acts in court, but it's not, the current administration can't bind the hands of the next administration in areas where the administration has extensive powers.
Okay. But just so everyone knows, I'm going to try to get all these questions, but I know there's a lot of questions, so I don't know if we'll get to all of them. And I'm sort of skipping around as I can. Kennedy has talked about sweeping cuts to federal agencies, such as firing, 600 NIH scientists or eliminating whole departments at the FDA. How realistic is that threat? Like, wouldn't a lot of those employees be protected from federal union rules or labor protections? Or is there, is there, what would happen there?
So a few points. One is Kennedy is not the is not the nominee for director of NIH. So again, we'll have a question of how much power will that nominee have and what will that nominee want to do? Second, yes, many of the people working in NIH, CDC, etc., are tenured civil servants that have some protection. However, those protections are constitutionally vulnerable. One of the reasons they survive is that previous presidents respected them as a matter of norm. And for example, one of the questions talked correctly about Trump suggesting that he'll increase, that he'll put a lot of civil servants on a Schedule F that makes them easier to fire and not subject to the same protection. So a lot of civil servants may lose some of their protection, and that could well survive judicial review because the court has increasingly emphasized the president's role as the head of the executive branch and will give the president substantial leeway. So I would not assume the protections will hold if they really want to fire large numbers. But if they want to get things done, they need people. They probably don't have 600 qualified people able to take those positions immediately. So if Kennedy has a bit of a dilemma. If he wants to make a lot of changes in HHS, he needs people who can do that. If he wants to fire a lot of people, that would leave gaps that would make it harder to put in an agenda. He's going to have to choose.
That actually kind of addresses one of the other questions, which was asking if Trump engages in that widespread firing, it seems like it'd be very hard for them to then hire and appoint people because there'd be sort of the bureaucracy would grind to a halt, right? Is that pretty much accurate?
Yes, and also people might be more hesitant to take positions if firing is such a clear, at least qualified people. They need people not just that not just warm bodies, but people that can do it in a way that has at least some chance to survive judicial review.
Okay.
And remember that, for example, Siri may not want a position in the civil servant because if he wants to litigate cases and make money there, that can be intention.
Yeah, I think he said in that New York Times story that he wanted to stay outside of the administration so that he can bring cases to the government. Do ACIP recommendations have to be certified by the CDC director to have their statutory powers with regards to Vaccines for Children program, or are they independent? Like if the CDC director disagrees with what ACIP says, who determines the coverage for the Vaccines for Children program?
VFC is specific to ACIP. The recommendations that affect the Affordable Care Act coverage need the CDC director approval, but VFC is under ACIP.
And then what can you talk a little bit about states here? There's several questions in here related to states, both how vaccine access could be blocked or impacted at the state level, but also how states could fight back. Like if if vaccines are unrecommended, what effect would that have? It sounds like that would stop the Vaccines for Children program from covering those. But
Yes.
what else? What would happen at the state level there?
So a few things. First of all, if we're talking about not recommending, states would probably vary in their following of lack of recommendations. So states may have different views. And I will remind you that states are important political actors with the ability to pressure an administration. So if states that are ruled by Republican governors are concerned about access to some vaccine, they can talk to the president that represents their party and advocate for having the vaccines in their state. So one thing is states are powerful advocates for issues. They can also bring cases against specific measures. If there's a measure that denies access to vaccines to people in the state, a state can take it to court. In addition, states can choose to offer coverage, insurance coverage of vaccines themselves. States can go beyond federal requirements of insurance coverage. There's a limit to how much they can fall under it, if they can, but they can go beyond that. I will mention that so states can't recommend things for ACIP, but during COVID, for example, some states created their own boards to review COVID vaccine. And I can imagine some states saying, we no longer trust this ACIP that's full of people we don't trust. We're going to create our own board to make recommendations in-house. Those recommendations won't be ACA and VFC recommendations, but a state can do that and add an insurance program. It will cost money.
If ACA is repealed, since that was one of the stated goals, though we don't know, how would that affect the possibility of attempting to fight the revocation of ACIP recommendations in court?
If there's no practical influence to ACIP recommendations, there's not a lot of reason to go to court, and there's not a lot of basis for court actions. On the other hand, if the Affordable Care Act is repealed, and remember that there's a lot of options there. There are provisions in the Affordable Care Act that are popular across the board in the nation. And the Trump administration might hesitate to overturn that. In recent times, President Trump made some comments about that suggest that he's not going to wholesale repeal the Affordable Care Act. So it depends what will be done and how. If the preventive services provision is repealed, and we don't know that will happen, then it'll be less important what ACIP recommends or not in terms of coverage. It'll be important in terms of influence, but not in coverage. So there'll be less goal of going to court. I will also add, in terms of the preventive services, that I didn't mention, but there's a court case that's not related to this administration that's challenging the preventive services measures of the Affordable Care Act. Redwood versus Becerra is the name of the case. And that case, the lower courts have upheld ACIP recommendations as legal, but have struck down the PrEP recommendation of the United States Preventive Services Task Force, and that's going to go before the Supreme Court soon.
And just to let people know, if you search our website, you'll find some writings on the Becerra case. We've written about that. If the HHS Secretary can reverse emergency use authorizations, that means, for example, that he could reverse currently the children's COVID vaccine is currently under an EUA. He could literally just kind of with the swipe of a pen get rid of that. Does that also include home tests for COVID?
Those that are still under an EUA, but it's specific. He doesn't. You reverse a specific EUA. I don't know if he'll bother with testing as opposed to
Okay.
vaccine. But yes,
Um,
in theory you can.
Thinking in terms of not just vaccines, but if we have an outbreak, for example, we've got this bird flu is kind of, threatening, hanging over our heads, and the gods may decide that we're going to get another pandemic for another Trump administration. What would be a dysfunctional response from the HHS to that outbreak? Like if we get bird flu, what are some of the worst things that could happen or not happen? And I don't know which of you is better
I think
to
that's
respond.
Dr. Offit's question.
Well, to calm the waters, I don't think bird flu actually will ever become a pandemic. That virus has been around for almost 100 years, and it doesn't. There's 16 different. Well, influenza is a bird virus. There's 16 different types of influenzas that infects birds. 16. Only 3 of them have ever caused pandemics in humans. H1, H2, H3. All the others have never done that. The reason that they've never done that for all these years is that those viruses, other non-H1, H2, H3 viruses, don't bind to cells in the upper respiratory tract. And if it doesn't bind to cells in the upper respiratory tract and can't reproduce in the upper respiratory tract, then it's not going to be easily transmitted from person to person. So I really don't think H5 is going to be a pandemic, but there'll be another pandemic. I mean, we've had 3 coronavirus pandemics in the last 20 years. Assume that, we've had Ebola, we have increasing dengue, we have Zika. I mean, there'll be another pandemic. I think a dysfunctional response would be to ignore it. I really do think Donald Trump the first time just wanted to sort of close his eyes and hope it went away. Remember in April of 2020, he said, this is going to be gone by Easter. And he didn't want people to get off the boat where, on the West Coast, because that would increase the numbers. So ignoring it and hoping it goes away is one way to not deal with it. The other way to not deal with it wasn't dealt with, which was would have been to use, say, the Defense Procurement Act to be able to buy things like masks and gowns and ventilators. And instead, the states were left on their own. I mean, at our hospital, we had nurses wearing, bandanas for masks, wearing garbage bags for gowns. There was no reason for that. And that made it much, much harder. There were other mistakes that were made. I mean, leaving the testing all to the CDC was a mistake. I mean, they very quickly should have been farmed out to commercial pharmaceutical companies, to commercial testing companies, et cetera, to make those tests, and even in a competitive way, because to put all your eggs in the CDC basket was a mistake. We were much slower than other countries to get tests out there, which didn't enable us to get hotspots out there. On the other hand, kudos to Operation Warp Speed. I mean, I think that was one of the greatest scientific or medical accomplishments in my lifetime, and I'm old enough to remember the polio vaccine. So I think it was a production effort. The research effort had already been done, really, but that was a production effort. And I think it was remarkable. Basically, you bet $11 billion to bet on 6 horses to win 1 race. And it was remarkable. So there was the good and bad. But I do think, hopefully we've learned from this last one. But what worries me the most is I think there's been such pushback on any sort of public health mandates like masking or testing or vaccinating, that I think we leaned into this libertarian left hook, and people don't want to follow public health recommendations.
Dury, you mentioned that pharmaceutical companies could sue against losing vaccine approvals, and that would go to the courts. Could that make its way up to the Supreme Court?
Yes, and which way the Supreme Court will go will really depend on what the claim is. As a reminder, the Supreme Court has rejected, for example, the claims against the mifepristone and the claims in Mercy versus Missouri against government in relation to social media companies. It's going to be very much a question of what are the details. What's the claim? What exactly did the FDA do, and what's the basis for it? It's going to come up with a record from the courts below that's pretty technical, so hard to predict what will happen.
This one's for Paul. Should adults consider getting boosters of childhood or other vaccines to guard against the potential erasure of herd immunity if Kennedy is successful in getting rid of certain vaccines? I mean, should people be sort of going and getting whatever they can now, or is that panicking or
Yes, that would be panic, but I think just make sure you're up to date on your vaccines. I mean, if you're an adult and you're of a certain age or you have any sort of medical problems, make sure that you've gotten the shingles vaccine or gotten the pneumococcal vaccine, to get your influenza vaccine. Just be up to date. I wouldn't try and like just stockpile your immune system by getting as much as you can right now. Just make sure you're up to date on your vaccines.
this one's also for you, Paul. Let's assume that RFK Jr. is confirmed, and under his leadership, previously reliable sources of information like the CDC and the FDA websites are now promoting, rather than refuting, anti-vaccine information.
Mhm.
What kinds of things might what could happen in terms of sort of using a sort of quasi bully pulpit to change the information? Like, would CDC become a source of misinformation in that case? And what could health authorities and experts outside of the government do to counter that?
Right. Again, I mean, if you believe all politics is local, I think all public health is also to some extent local. And so I think that there are people either in states or in localities who cared very much about this. I mean, people who are in public health who care to do this all for the right reasons, and parents who care very much about this. I think there will be an enormous backlash to that, a real pushback on that, because we do care about our children's health. I mean, vaccines. Mumps was the most common cause of acquired deafness. Rubella was a common cause of birth defects. 20,000 cases a year. We've basically eliminated hepatitis B in young children, where it would cause 18,000 cases a year and increase the risk of liver cirrhosis as well as liver cancers. Vaccines, we've benefited from vaccines tremendously. And I do think that that not only have we largely eliminated diseases, we've eliminated the memory of these diseases. But I do think that they're going to. What I think is going to happen, if I had to make a prediction, I think measles. I think measles are going to come back, and I think meaning in a big way. And so when I deal with the medical students now and the doctors who largely have never seen measles, I want them to understand who should come into the hospital and who shouldn't. But get to a few thousand cases of measles, and children will start to die again. And get to more than that, and then what you'll start to see is sporting events getting canceled because there's an outbreak of measles in a hockey team or something like that. I think that is perfectly possible. This is a highly contagious disease. You don't need to have face-to-face contact. You just have to be in someone's airspace within 2 hours of them being there. It's that contagious. It has a contagiousness index of 18 compared to 2 to 4 for SARS-CoV-2 or flu. It's really contagious. And we've gone from 50 cases last year to 250 cases this year. Measles is what worries me. I fear that Donald Trump is about to become the president of measles land.
And this is also for you. You discuss in your book Bad Actors that they're, the people who are sort of these celebrity politician experts, right? That, Kennedy, Gwyneth Paltrow, people who think they know the science that don't actually know it. What can journalists do to push back on that, to sort of displace the misinformation that's being promoted by those people?
Right, bad advice. Is that what you mean, the book Bad Advice? That one, yeah.
Oh,
So
yeah, yeah, sorry.
yeah, that's right. But it included a lot of bad actors. I mean, I think journalists represent that thin blue line right now between fact and ignorance. I mean, I think the job has never been more important than it is now. And what worries me sometimes about some journalists is that they have this mantra of balance, which you tell two sides of a story when sometimes only one side is supported by the science. I mean, this isn't, whereas philosophy can be debated or religion can be debated. Science, there are truths that emerge, and when they emerge, that's that. I mean, this sort of open-mindedness of representing both sides when only one side is supported by the science doesn't help anybody. So be brave and get out there and have perspective, I guess, arguably, instead of balance.
And then, Dorit, are there things that Kennedy can do that we haven't already discussed that would be very, like, was there anything he could try and do that just has never been done before? Or what are we not thinking of that he could, try and attempt?
Uh, I think we've covered a lot of ground of things that he can do. To echo Paul's point, remember that, so we're talking about Kennedy, but I also want to remind everybody that we have a nominee for the CDC that believes vaccines cause autism, and he's probably more with a hand on the misinformation booth. He can change the page where the CDC says vaccines don't cause autism. As for Kennedy, I think that besides the things we've talked about, he can really push the people in HHS that have been the bulwark, that have been standing for expert information, etc., to resign. So that's it. Even without firing, just getting people to resign. The other thing is putting pressure on states through the 317 program, which is a funding program that covers immunization grants for all states and 8 cities, to either weaken their vaccine mandates, which is a state issue, but the federal government can put pressure on it, or reduce the vaccination efforts more generally. So I can see those happening. And we consider some of the petitions that Kennedy himself, through his organization, and ICANN have submitted to FDA. He can put pressure on those as well.
I just realized we're at 1 hour right now. I might try and see if we can go. And by the way, this is being recorded, so if you guys need to, if anyone wants to come back and watch this again, they can. Do you guys have about 5 more minutes to ask a few more questions?
Sure.
We don't usually go long, but I want to try. There's a lot of questions. Can Kennedy or anyone else in the government try to defund the Vaccines for Children program, or try to use Medicaid as a weapon to withhold Medicaid from states that keep their vaccine recommendations for schools?
The Vaccine for Children program is in the statute, and it's a benefit program, so they can't directly defund it. They can remove specific vaccines from being included in the program. Medicaid, so in the Supreme Court found that withholding Medicaid funds as a tool to expand Medicaid in 2000 in the original Affordable Care Act was unconstitutional because it was too coercive. And that ruling would probably go to withholding Medicaid funds generally. But if you have good connection with a person running the Center for Medicaid and Medicare Care Services, you can work on reducing access to some of the services. Some of them are in statutes. For example, some Medicare vaccines are covered in specific statutory provisions. Others are just in Center for Medicaid and Medicare rules. The Medicaid itself, some of it is in statute and some. So to some degree, is a short answer of a complicated issue.
Are there ways that this is for Paul, are there ways that the incoming administration, how might they impact vaccine research in the US? Like, could they, for example, try and push for fund, and I know some of this might be through the NIH, push for funding that finds more vaccine harms, for example?
Sure. No, this is what worries me. I mean, when RFK Jr. says, I want to do the kinds of science basically that he believes in, that he trusts. What he means is science that supports his point of view. I mean, there's 8,000 papers published a day in the medical and scientific literature internationally, and they follow a bell-shaped curve. Some papers are great, some papers are awful, most are more or less mediocre. He could just select those ones that support his point of view, because you can find a paper that supports anything, right? Andrew Wakefield published a paper claiming that the MMR vaccine caused autism when it didn't. So, and he could just highlight that and then make policy based on that. Yes, this really worries me. This man has for 20 years been a vigorous anti-vaccine activist. He really believes it. He's a believer. He believes that vaccines have traded in infectious diseases for chronic diseases. When he says, when I see someone walking along a path when I'm running, I will go up to when they're holding a baby, and I'll say, don't vaccinate your child. This is someone who's about to be the head of Health and Human Services. I just think we should believe him. We should believe what he's been saying for the last 20 years and trying to make him into being something that he's not.
And that seems like a good place to stop. Is there any last words that either one of you want to throw out there? I'm sure there's lots of other things we could delve into, because it's kind of, like I said, some of this
Just a reminder, he has not been confirmed yet. This is a time to explain the problems, warn people, and make sure the senators have the facts before them.
Excellent. Thank you, everybody. I really appreciate you all coming here. Please remember that this has been recorded, and you will have the opportunity to look at this later. You will have the chance to view this later. Thank you, everyone, for tuning in. The recording will be at healthjournalism.org in a few hours, and AHCJ will continue to bring you webinars on a wide variety of topics, and probably, hopefully more uplifting than this one in some cases. So thank you, everyone, for coming, and thank you, Paul and Dorit, for sharing your expertise.